Hi, everyone. We'll get started in just maybe 2 minutes or so. Okay, so I think we're gonna go ahead and get started. I want to welcome everybody today to the third of our 6 kind of workshops, webinars in setting the stage for screening, ACEs screening and trauma-informed practices, particularly for small practices. This third webinar is all about the clinical encounter. So exams, tests, and procedures, and how do we do all of those things in a trauma-informed way. Next slide, please. So just a reminder, some of you have probably been with us were with us for the first 2 webinars out of the 6. If you were not here for the first 2 webinars, but you're interested in those topics, our coordinator, Kimmy, will put the link in the chat box. They're all archived on our website. So you can go ahead and take a look at those if you're so inclined. And then after this, we have 3 more webinars, as you can see here. The last webinar, we're still deciding on the topic. So if you have anything that you're really interested in learning more about, feel free to, write to us in the evaluation or in the chat box or both. That would be great. So I also wanted to, for those of you who have been with us before, I wanted to tell you that, in the past, we've really done about an hour of content and then stayed on the line for discussion and questions and conversation for that second hour. Because the clinical encounter, we really have a lot to say about it. What we're going to do is we're going to do more about 1.5 hours of content, and then we'll have about a half hour at the end for questions. If for some reason you cannot stay on for the 1.5 hours, again, we totally get it. This will also be recorded and archived on our website. So if you need to miss some of it, you can always come back and look at it. Next slide. So just a quick reminder, I'm Yael Lipton from Primary Care Development Corporation. My co-facilitator is Angela Fernandez from a program in New York City called the Sexual Assault and Violence Intervention Program. I don't want to spend a lot of time, introducing myself again, but I'll just say that this program is brought to you by the ACEs Aware initiative that's going on in California right now, the first of its kind in the nation, which is really exciting. And just a little bit about me, I'm a health educator by training. I was providing direct services in New York City and underserved communities for many, many, many years of my career, and then really focused on training and capacity building, for healthcare providers working in those same communities. So I do a lot of training, I do a lot of curriculum writing, and we've now had to transition to everything online. So we're doing the best we can. But basically, we really hope that you will participate and ask questions. We'll monitor the chat box as best we can. My areas of expertise are really around program planning, program implementation, helping people with behavior change, health education, trauma-informed care, person-centered care, and team-based care. So that's a little bit about who I am, and then I'll have Angela introduce herself, and we'll get going.
Thanks, Yael. Good afternoon, everyone. It's wonderful to be here with you again, or for the first time. As Yael said, my name is Angela Fernandez. I'm currently the Assistant Director for Mount Sinai Sexual Assault and Violence Intervention Program. Similarly, I started my career as a health educator, specifically a sexuality educator, and really, fell in love with with community education and curriculum development, and that really led me into really focusing more specifically around gender-based violence after focusing more broadly on reproductive health. And I've been doing trauma work basically for the last 13 or so years. And in addition to more of the boring admin stuff that comes along with an assistant director role, I also get to do a lot of work around training and building capacity for providers who are first responders to people who experience sexual violence, intimate partner violence, and those forms of trauma, and really also help to improve more broadly wraparound services and coordination for survivors who've experienced this form of trauma, which is why I'm really excited to be able to partner with Yael again doing this work because it's so important. So really excited that you're all here with us today. Next slide, please. So our learning objectives that hopefully people will walk away with today, just being able to explain better the impact of clinical encounters on people with trauma histories, identifying re-traumatizing aspects of clinical encounters like exams, tests, other types of procedures. We're going to focus a little bit around describing what it means to make clinical encounters more trauma-informed, explain how and why using health literacy principles in the clinical encounter is so integral to all the care, and list ways to improve or adapt these types of encounters to become more trauma-informed. So we're going to dive right in. Next slide, please. So as Yael said, we've been focusing on different aspects in this series, and today our focus specifically is around the clinical encounter. And you can see some of the things that we've already covered and some of what we'll be focusing on future presentations. Next slide, please. So what we'd like to do now is we're just going to start with a little bit of a warm-up exercise. So we have some case examples here, and I'm going to read each one, and then I'm going to ask people to just chat in the to add their responses in the chat box, and just let me know what are some examples in the particular scenario that you feel are not trauma informed or things that could be improved. So we're going to start with the first one, which is a heart health visit. Jess is an established patient and is taken back to the exam room where they're told they will need to undress for a test. They're handed a gown and then left alone to change. When the doctor comes back into the room, he entered without knocking, which caught Jess by surprise. He proceeded to tell Jess that he will be conducting an EKG with no other explanation, and was told to lie down on the exam table. Jess was confused and visibly anxious, but didn't feel comfortable to say anything or ask questions. So we're not going to spend a ton of time here. This is just to get you to start thinking about in the framework of what our topic is today. Can I see some responses in the chat box and let me know What stands out to you in this particular scenario that is not trauma informed? Okay, no instructions, didn't ask permission, lack of personal empathy. Mhm.
Oh, I can just add quickly that if you're chatting in, there's an option where it says to, you can click on it and you can say to all panelists and attendees. That way we can all follow along.
Oh, thanks, Yael. And a thank you for Yael. Entering the room without knocking. Yes, not setting expectations. Awesome. Yeah. Yeah, so right, this is a small example, and I'm sure many of you can relate to having something similar happen even in your own medical experiences. But absolutely, right, even in this short example, we can identify some things that are clearly not applying some of the trauma-informed principles that we've already covered and that we'll be going into more detail with today. So let's move on to the next one. This is a wellness visit. The MA is the first person to talk with this particular patient. They stand at the computer and don't make eye contact with the patient as they go through the checklist of questions and prepare to check vitals. The temperature is taken first. The MA tells the patient to open their mouth and then pushes the thermometer inside. It is pushed too far back and the patient begins to gag. So any responses that you want to add in the chat box on this one? What stands out to you? Communication about focus of exam, what's recommended, not knocking when patient is visibly anxious, not stopping and asking patient. Yes, thank you so much, Deborah. That's totally on point for the heart health visit. Yeah, Diana, lack of eye contact and being personable. Absolutely. I always think about, Yael always has a great anecdote when we talk about just even like moving from, paper notes, patient files to the electronic health record, about, a provider saying once, I used to take care of patients, but now I take care of my computer, right? So, and it's something we can't avoid, definitely in medical visits, but we're going to go into more detail about things that we can do to get what we need to get done, but also do it in a trauma-informed way. MA should have introduced themselves in role, instruction, explain temp check, ask permission, ask to open mouth versus telling to open. Absolutely. And I'm seeing some familiar names, which is great. So awesome to have everybody back in the room with us. Okay, next slide, Kimmy. So, for all of us, we've all, I'm sure, interacted with the medical system for our own experiences. And we'd love to hear from you if you're comfortable with this in telling us in the chat, like what elements of a primary care visit have made you feel most uncomfortable or, even most anxious about before you get there. And then similarly, what has made your children, if you have them, most uncomfortable and why? Yeah, no eye contact. Certainly the no eye contact is really hard. Judgment. Yes. Personable interaction. Normally it feels sterile and procedural. Physical roughness during a PAP. Yes. No emotion. Having to remove clothing at all. Sitting in a cold room naked except for a gown. Oh, a couple minutes can feel like an hour, right? When we're in those vulnerable situations. Thank you so much for being so open about this. What questions do you have? Not do you have questions? I feel like it is always rushed. Absolutely. Thank you. All of these are excellent points, and I think that you're already warmed up for where we're going in the next, hour, a little over an hour together. So, thank you for doing this with us. And and this really does just set the tone for what we'll be talking about, right? All of these things that They don't have to be big examples of things that can be adjusted or tweaked that can make all the difference for an experience, right? And how we think about it, how we're preparing for it, and how we feel about it afterward. Next slide, please. So, tying this back to trauma, and this isn't going to be anything that you all haven't already said in the chat box, but clinical exams, procedures, tests, they can be triggering because of their invasive nature, right? Most of these things are they're scary. It's very normal to feel anxious about them. People who have trauma in their history, though, are probably more likely to delay or avoid procedures that, in the medical world are considered normal or routine, like a PEP, colonoscopies, vaccines, dental care, right? The annual physical. That it's hard to, squeeze that in for many of us, but can really feel dreadful for someone with a trauma history. People may seem anxious or disconnected or distracted before and during the visit. It's really, thinking about when we interact with our patients, what we, again, might expect a person to act like versus how a person's experiencing it because of their trauma history. And a person who is triggered may behave in a variety of ways that seem strange or off to the healthcare staff, right? There is no one way, there is no one right way to respond to trauma or to cope with trauma. And so it's going to look different and feel different for each person. It's also going to appear differently through each one of, from our own perspective, because we're not immune to this either. So, really recognizing what's happening for the patient and also how we're interpreting that as the providers. And patients don't always know what their triggers will be, right? So oftentimes we may expect that a person's going to know and that they are managing it or adapting how they need to. But the whole, the definition of a trigger is that, it's happening to you and can really catch a person off guard. And so patients aren't always going to know. Next slide, please. So why are these things triggering? Well, if we think about trauma, again, it's going back to that root of feeling a lack of control or autonomy just by nature of a clinical setting. And that is exacerbated by not knowing what's going to happen next in the encounter. And then also, if someone has to expect results, not knowing what's going to happen with that as well. So there's a lot of unknown and a lot of things that are out of a patient's control, which is exactly what a traumatic experience is, right? When we experience trauma, it's that same thing. It's often something that's being done to us, not with us. Some of you, made that very astute observation already with those scenarios that, this is not, oftentimes our medical experiences are not collaborative, right? We're being told what to do and we do it. So there's definitely an overwhelming feeling of powerlessness in these settings. Low health literacy. People may not fully understand what's being done, the reason for it, and what the next steps are. And sometimes you don't know what you don't know. So again, expecting a patient to speak up or to ask the right questions is really making a huge assumption and an unfair one, right? With medical procedures, our bodies are being invaded, touched, examined, right? Poked and prodded. These things can sometimes be painful. And, what does that mean for each individual person? The environment is often uncomfortable. Someone said sterile before, absolutely. Cold, gray, right? Medical directions are usually given as orders. There's no input from the patient. And as patients, we all fear receiving, bad news about our health, right? I mean, I don't know about you, but if you have a headache, it's not, it's just a headache, right? Many of us go to worst case scenario. And that's a part of really coping and trying to get control over something that we feel is out of our control, right? Next slide, please. These are just some quotes from patients and also from providers around clinical encounters and how it really intersects with trauma, right? So we have one here that says, I don't want anyone to touch me, right? I'm not getting a colonoscopy. They aren't going to put me under. Do they think I'm stupid, right? Sometimes we have patients, the patient was shaking and trembling while I conducted the pelvic exam. I was very gentle, but it didn't seem to matter. So really for providers thinking about, what did I do wrong rather than there's something going on here, right? The top, right one, I put my hand on his shoulder and he jumped back and looked ready to fight. What did I do wrong? So again, it's this whole entire, series is focusing on broadening the way that we understand trauma and looking at it, that it's not so black and white as far as right or wrong or good or bad, but that, every experience is going to be unique and each person brings in their own, their own experiences into it. So we really have to kind of get back to that person-centered approach. And person-centered really essentially is trauma-informed, right? Next slide, please. If we, kept this in here from previous slides, just to again remind ourselves what we're talking about here. So trauma-informed approach, again, it promotes safety, it promotes well-being, healing, dignity, respect, and really tries to minimize some of the things that are commonly experienced, especially in a medical experience, right? So adverse stimuli, we want to reduce environmental stressors. We definitely don't want to re-traumatize our patients. And we want to minimize the feeling of loss of control, right? That perception. And when we do that, we can create, a sense of safety and trust. And when we have that, then, the outcome is going to be more positive for everyone involved. Yes, someone here said approaching every individual with kid gloves is necessary. Trauma is more prevalent than we realize. Absolutely, right? That and trauma-informed approach again, right? It's looking at it and assuming that everyone is coming in with a trauma history rather than assuming that they're not, right? So really a universal approach. So thank you very much, Marianne. Next slide, please. So again, we've said this already, but this is all about relationships. And really what we're trying to accomplish here is trust. So what might be harmful? Well, interactions that are humiliating, impersonal, disrespectful, encounters that are rushed and abrupt, tone that's demanding, someone said earlier, judgmental, absolutely, condescending, a lack of mutual collaboration, and to keep in mind that language that we use can be harmful. We're going to go into more detail about that later. So what are the things that are helpful? And this may seem, really simple, but we all know when we're in it and we're doing our job, it's not as easy to incorporate these things with every patient as it may seem up on a slide, right? So our interactions that express kindness, reassurance, acceptance, saying things like please and thank you, and providing positive affirmations to our patients is important. Establishing a pace that conveys patience and caring, active listening, and plain language, which Yael is going to go into some really great detail about later. Next appointment. I was reading a message there. Okay, so the importance of our attitudes and beliefs in here, and this could be an entirely separate training series, so we're just gonna keep this brief, but happy to go into more detail later in our Q&A time. But what's harmful, and this is a really great opportunity for all of us to check ourselves, right? Asking questions that convey the perception that there's something wrong with the patient, right? And again, this isn't about necessarily our intention, but to be mindful that what we perceive about ourselves and what's actually happening aren't always the same thing. So judgments and prejudices based on cultural ignorance, regarding a person's difficulties only as the symptoms of a mental health, substance use, or medical problem. What's helpful? Asking questions, for the purpose of understanding what harmful events may contribute to current problems, right? So getting to know the person and their story, understanding the role of culture in trauma response, and recognizing the symptoms are often a person's way of coping with trauma or our adaptations. And those are things that have been working, maybe not in our definition of health, but coping strategies are working because somebody is trying to survive, right? And trying to cope. And so they might not be the healthiest, but to disregard them is, not helpful. Next slide, please. So again, this could be something we would unpack over a year together, but I think we just want to make sure that we bring attention to this. So culture, gender, and historical considerations, which is really a part of the overall trauma-informed principles. So thinking about, what privacy and modesty may mean based upon a person's cultural identity, gender, and also historical considerations when it comes to gender identities, culture, race, that these things are important and essential in thinking about and learning more about with each individual person. Language, so what language is most comfortable for a person to use in these settings. Thinking about what cultural competence versus cultural humility mean, right? And so we never want to feel like we can check cultural, understanding different cultures off a box. That cultural humility really is the acceptance of understanding that we'll never, every person's unique. So rather than feeling like we can be an expert in everybody's shoes, having the humility to know that we don't, right? Eye contact and other nonverbal cues. And again, this is really important to follow a patient's lead, because what we consider respectful or disrespectful could be something entirely different based upon a person's cultural experiences. Systemic racism and sexism in the medical field. I think we're seeing this play out in real time with the pandemic and with testing, and now even thinking about the vaccinations, right? That there are some communities that rightfully so have a lot of distrust and hesitation in the vaccine, and why, right? And feeling like, again, that they're being used maybe as a form of research or guinea pigs. And rather than just disregarding that, understanding that this is very valid and that we have to find ways to earn that trust with our patients. And again, personal space and boundaries, that there is no just one definition, that it really should be determined by what's comfortable for our patient, not what we decide is correct. And again, Western medicine versus some more traditional and alternative medicine. And how can we take that and use it rather than just saying some things are wrong? Because that's how we earn trust with our patients. And if we want people to disclose the truth to us, then we have to really be open and ready to hear anything our patient tells us. Next slide, please. And so Yael's going to go into a lot more detail around some of these things, but communication definitely falls within those identities too, right? And communication goes a long, long way in all of our relationships, not just with our patients, right? I am humbled by this concept almost every day, foot and mouth experiences, right? With communication, especially with patients, though, we want to speak clearly, we want to speak slowly, and we want to speak at an appropriate volume. We, again, want to mirror what's happening in the room with our patients and really meet them wherever they're at. We want to use the preferred language of the patient, not what we have decided, right? Using things like ORs from motivational interviewing, so open-ended questions, affirmations, reflections, summaries, so that our patients really know that we are doing our best to hear them, understand what they're trying to convey, and that we want to hear. Things like using plain language, appearing engaged and pleasant and calm with our patients, which is sometimes really hard when you're running around and have a ton of people that you have to see in one day, right? Maintaining appropriate eye contact, sitting or standing at eye level with the patient, depending on what types of exams and procedures are going to happen. We want to avoid sudden movements, keeping our hands outside of our pockets. And then again, it's not just about our communication, but really paying attention to patient cues. What are they saying and what are they not saying? So things like tensing muscles or fidgeting, breathing quickly, flushing, crying, trembling, all of those things are communication and we need to pay attention. Next slide.
Okay,
I'm handing it over to Yael.
I'm going to take it from here for a little bit and then you'll get Angie back. So we have brought up health literacy before. When we're bringing it up again, because it's really an integral part or component of trauma-informed care. So we actually do tons of health literacy training that can be days long. And I'll try to sum up some of the things that we do training on, in a couple of minutes. We have, as many of us know, that we have a literacy crisis in the US. About a third of all Americans read at an 8th grade level or below, but we also have a health literacy crisis or challenge. Health literacy, while related to general literacy, is not the same. So health literacy is really about being able to understand and act on health, medical, and scientific information in order to become healthier. And many people, really, regardless of how educated or literate they are, really struggle with understanding health, medical, and scientific information. And this has a direct impact on health outcomes and adherence, as we like to say in the healthcare world, although I don't really like to use that term. I always use the example of my mother, who is a college educated person who reads several books a week, reads the New York Times every day, very, very smart, but really struggles with health information and has a lot of health problems. My father died a few years ago and he was very health literate and would go with her to all the appointments. So anytime I would want an update, I would ask him what happened. Now I have to ask her, and needless to say, I have no idea what's going on unless I go with her, which I'm unfortunately not able to do because we live in different states. So as you can see from the picture here, people with lower health literacy are more likely to use the emergency rooms. They have longer hospital stays. They're less likely to follow treatment plans. And unfortunately, they die earlier and get sicker than those who have adequate or high health literacy. At a minimum, we suggest using a few techniques to help in your work. The first one is called the need to know versus nice to know technique. And this is really about thinking about what information patients actually need to act on to improve their health. So we often like to give out tons of information. And while some of it may be nice to know or interesting to some, not to everyone, it's often not need to know. This is really not an easy thing to do, but we wanted to mention it to get people thinking about that concept, right? It's if people are really struggling with understanding what is happening and what their directions are, to be healthier, we really want to limit the amount of information that we give them. So the next is using plain language, and we're going to see some examples of this in the next slide. So I'll hold off on this, but basically this is really about replacing medical or scientific language with language that more people will understand. And it sounds simple enough, but actually we found that this is probably one of the most challenging things for people in healthcare to do successfully. Using the teach back method is another tool, which we'll also review. And also we suggest using educational tools, right? Use what's out there, short videos, giving out pamphlets that are health literate and reinforce the education that was already done. Using 3D models, having posters up can be helpful in showing patients, what you're talking about. Next slide. So here are some, examples. This is obviously not going to be everything, but we really do believe that language can harm, and it can harm even when we really don't mean it to harm, and we're just being professional. So here are some examples. So I'm going to check your vitals now. Okay, we all know, most of us on this call probably know what that means, but we would suggest saying, I'll be checking your blood pressure, your temperature, and your pulse next, right? It's conclusive that your diagnosis is diabetes. We will need to set you up with a CDE and a nutritionist. Okay, so there's a lot of problems here. So you could say something like, the tests that we did show that you have diabetes. I'm going to take some time right now to explain what diabetes is and answer all of your questions. I know this may be surprising. You may feel scared or nervous. That's completely normal. We're going to take this step by step and create a plan together to take care of you. Again, there are many ways that you could simplify these things. These are just some examples. We will have to monitor your weight and blood pressure. We'll need to keep track of your weight and blood pressure for the next few months. Let's review what a healthy weight and blood pressure would be for you. How does that sound to you? If you feel nauseous or short of breath, discontinue the medication. If you feel sick to your stomach or have trouble breathing, stop taking the medication and call me. And just a little fun anecdote. People who struggle with literacy and health literacy, they often don't understand what we call like the prefixes, right? So the dis and the discontinue. And what they will often do is they will look at the part of the word that they do understand, which is the continue. They know what continue means, but they're not sure what dis means. So oftentimes in those words, people end up doing the opposite. So really pay attention to those. Next slide. Okay, so we suggest replacing normal with healthy, right? So your blood pressure and cholesterol within the normal range, as opposed to your blood pressure and cholesterol are in the healthy range, which is great. Why do we suggest this? One, because it's more specific, and really because it's less stigmatizing, right? And actually, for many people and some families and even communities, normal may actually be unhealthy, right? So I have done a ton of work in the South Bronx in New York City, and that particular community has the highest rates of asthma in the entire country. So asthma is completely normal per se, right? Oh yeah, no problem, Angie. Asthma is normal. Everyone has asthma, but that's not what we're actually trying to say, right? It may be normal, but it's not healthy, and we don't want that. So please scoot your butt up towards the end of the bed. Can you move your bottom towards the end of the exam table? Again, scooch is not a word that everybody will understand. And the exam table, we certainly don't ever want to refer to it as a bed, right? Many people have had bad things happen to them in beds. Stirrups, we would say footrests instead. I think that's self-explanatory. And again, instead of that looks good, that looks healthy, right? In the last one, I know probably some of you are chuckling here, but we never want to presume what might be relaxing for someone, right? Some people may not relax at the beach. Some may have never been to a relaxing beach. Or someone may have been hurt at the beach. So making it more person-centered is really the idea here, right? Obviously, for many of us, the beach might be something that makes us relax, but for many of us, it hasn't been. And people may not have even ever been to the beach. Okay, next slide. Okay, so I absolutely love the teach back method. I use it all the time, both professionally and personally. And really, it's really about asking patients to explain in their own words what they're going to be doing when they leave the visit. So whether or not you've prescribed a new medication, whether or not they have to make an appointment with a specialist, maybe they need to bring in some extra documentation, whatever it is, right? The thing that we want, the thing that's important about the teach back method is that we want it to come off, we want to put the emphasis on ourselves and not the patient. So we basically explain it as we want to make sure we did a good job explaining this, because sometimes I rush, sometimes I'm not clear, sometimes this information is confusing and I don't do a good job explaining. So can you tell me, do you remember what, documents you're going to need to make that appointment? So again, the teach back method. If you Google any of these things, you will get tons of information. And if you want someone who's already done all the Googling, if you want to reach out to me, I can point you in the direction of lots of additional resources for this. And this is just some humor, right? So your medication says take with meals, no problem, right? I eat all the time. I eat 4 meals a day, 5 meals a day, 2 meals a day. Again, right, not helpful. Okay, next slide. Just checking my time. Okay, we wanted to share a real story with you that was written by a woman who has experienced sexual assault in her life. If you're interested in the entire account, you can feel free to Google the title and you'll find the entire narrative. So before I go over what's written up here that we've copy and pasted, I wanted to tell you that the background really is that Carol is a sexual abuse survivor, and she opens up her piece by writing, quote, "The one place I hate going most is where the sexual abuse I experienced continues to be played out time and time again, a doctor's exam table. There isn't a memory I have where the appointment wasn't invasive or traumatizing. I think the first being from around the age of 3. I was completely naked with my legs spread eagle on a gurney as a nurse inserted her gloved finger into me. A few years later, my already prevalent freeze response left me defenseless from a male doctor who lifted the hospital gown draped over me to view the private places of my body where chickenpox had spread. Visits to a doctor's office became increasingly worse from there." Okay, and then there's more. Then I wanted to share this part that's written. So a knock came from the door, which opened promptly before I could muster an answer. The woman who entered was of equal stature, but I felt small in comparison. I was intimidated by her demeanor and the line of questioning that ensued. She wanted to know why I still wasn't ready for an examination, but when I attempted to discuss it with her, she had no interest in hearing about my trauma history and the effects trauma had on me in a medical setting. Instead, she hastily interrupted me, insisting that she was well informed about the nature of trauma and vocally made the assumption that it was myself and my therapist who were at fault for clearly not working through the issue. Ugh. I was becoming increasingly worried that she was going to refuse to renew my script. But as the interrogation came to a close, she announced that she would hold off on an exam for another year, as if I should be grateful. She insisted that I needed a pelvic exam the following year, regardless if I was sexually active or not, and that if I still didn't feel ready, I should undergo sedation. When the word sedation passed her lips, I froze. This doctor truly believed that taking away all of my control over my body and my consciousness was a valid and less traumatizing option than listening to and working with me. She either couldn't see or didn't care that sedating me, so she could do what she wished to my body, was no different than not having control over what was done to my body during the sexual abuse. So take a moment. Any reactions to this? I want to thank Carol for sharing this actually with everyone, because it's such a good, a very obvious, right? A very obvious and clear example of how, probably well-intentioned people really triggered her and made and caused her to feel this way about pretty much all of healthcare. A humbling reminder of how much power we hold in healthcare. Yeah, yeah. What a missed teaching moment of a patient to a provider. Yeah. Right. Okay, thank you. All right, let's move on. Next slide. So we're going to look at these exams, tests, and procedures, and we're lumping them all together, although we know they're all different. We're going to really think of them in 3 stages. We're going to think of them in the pre-visit and the triage. We're going to think about what happens during, and then we're going to think about what happens after. So hopefully it's organized in a way that makes sense. Next slide. Okay, so before visits, this pre-visit planning can be done either the day before, in the morning before the day starts, or it can be done in huddles. So if you're working in a smaller practice, we've seen that the huddles that happen either, once in the morning before the day or twice, one before kind of each shift, right? One in the morning and one, maybe right after lunch. That can be an easier way to get these things done. It also really helps foster the team approach, which is perfect. So by reviewing who's coming in, you can really prepare for what issues or services they may need. So as an example, maybe there's a patient who's coming to give blood and that person always struggles with it. You can prepare yourself on how to manage the situation. For maybe this patient has a good rapport with someone at the front desk. So maybe your strategy could be that front desk person is going to be in the room with the patient while they get their blood drawn. That way you can plan for who might cover at the front desk. Again, I just made that up. It's just a suggestion. But again, that is going to be more successful versus having to scramble once that patient comes in and you realize, oh no, this is the person that's really going to have trouble, with blood. What are we going to do? So some things can also happen either on the phone during the reminder call or via text message or email if you have that capability. So again, as an example, if you know that you're having a problem with getting the exam rooms warm in the winter, and I think we talked about that earlier, right? If you're in a gown and it's cold, that 5-10 minutes can feel like 2 hours. Maybe, and the patient, the patient needs, let's say, a full physical where they're going to need to mostly be undressed or in a gown. You could perhaps on the phone or in that email tell the patient, right, that you're having this issue at the clinic and ask them if they can bring some sort of cardigan or shawl, that they can use to stay warm, or to wear warm socks, right? Or, whatever. You all have the answers and we can all be creative. The rest, let's see here. So one thing I want to talk about is asking patients to bring in medications for review. This is really a best practice for primary care in general, but it's also really trauma informed, right? Since many people who may be taking medications for things, mental health issues, or conditions that they may be embarrassed by, it can be easier for the provider to look at the medications and confirm what they're for and if they're being taken than asking the patient to list out all of their medications, right? Especially with people who are taking many different types of medications. They don't know the names. They don't know how much they're taking, right? And then the rest of the things I think really are self-explanatory here. Look at the chart. Is there trauma-related documentation? We also, Angela and I have done a lot of work with younger people in reproductive health. So one of the things that we would always say to look at is, it depends on your state, where you are. Most of you are in California, but where we were in New York, we would have things that would say like, do not mail anything home, right? Because young people can access all reproductive health without parental consent. And sometimes it would be dangerous, right? For someone to be billed an explanation of benefits or a bill or something to their home. So look for those kinds of things, put processes into place where that allows you to see them. Okay, next slide. So triage is as important as anything. While we talked about last time, the front desk and the environment really setting the stage, triage really sets the stage for the clinical encounter. So some easy to implement ideas are things like asking patients where they're most comfortable sitting. Usually patients are asked to sit up on those exam tables, but many don't feel comfortable up there, or they can't even get up there for some reason, right? And it may not be something that we could actually see that would make them uncomfortable or unable to get up there. clearly explaining, and someone said this in the chat already, the role of whoever is doing the triage is something we keep repeating, right? But it's really ideal, both in terms of best practices, but certainly for patients with trauma pasts who may be uncomfortable not knowing who is who and who is doing what, right? Like all visits, explaining what is going to happen, that's really key as well. Thinking about the temperature of the room. Again, if it's really cold in the room, is it really necessary for the patients to fully undress? Is there a warmer gown? Is there a blanket? Is there something? Let's see. One thing I definitely wanted to also say is that in smaller practices, there may be staff who are playing multiple roles. Maybe someone is a medical assistant, but also manages the front desk. So this becomes actually even more important to explain who you are, because it can be very off-putting if, you know, a patient goes into a room and they see, you know, Sandra from the front desk who checked them in, all of a sudden coming in and asking them, you know, why they're there. You know, they're gonna do their vital signs, et cetera. Okay, next slide. Okay, so the first bullet, so before the exam, the test, or the procedure. So the first bullet goes back to the pre-visit planning or the huddling that we hope is done beforehand, right? Know what you're walking into, who's in there, what is their history? Do they have a trauma history? Do they speak a different language? How long have they been waiting? Who else do they need to see, or who have they seen already? Observing body language and facial expressions, right? When you come in, what is it telling you? And then respond in a way that makes sense. If possible, and this could be harder in small practices, but if it's possible, meet the patient in an office versus an exam room while the patient is fully clothed. Again, if this is not possible, that is okay, but it still would be better for the doctor or the provider to meet the patient when they're fully clothed, right? That is for everybody, regardless of whether or not you have a trauma history, being in a gown or being partly undressed is always going to feel more vulnerable, and you're going to feel more threatened. Set an agenda, right, for the visit with the patient, not for the patient, right? And trying to be present, trying not to pay all of your attention to the computer. And Angela told you that story earlier, and that was an older provider of mine, my primary care doctor now, but she was new for me a few years ago. And within the first year that I was with her, they had changed EHRs twice. And so I remember she said that to me. Now I just take care of the computer, and it always stuck with me. If you do have some computer housekeeping, right? The computer is telling you there are things you need to do and they won't let you go on. We know how that works. Tell the patient that, right? That you have a few things that your electronic health record is asking you to do, and then you'll really focus on them and the visit. Ask about comfort using open-ended questions. So those really allow us, right, to get a better sense of how the patient is really doing, and allows them to share their stories, right? Not asking leading questions, things like everything's okay, right? Asking permission to touch, to move on. Offer a chaperone, or ask if the patient has someone they want in the room, really regardless of gender. Obviously, depending on the type of visit, then you may need to have some time that you're just alone with the patient to ask some very personal questions. But after that, you know, if it's going to help them, you know, why not? And speaking to the patient without the computer monitor blocking their view of you. So in red, I have mentioned how the procedure exam test will feel. So I wanted to just put this in quickly to say that this is really hard, because even something that, you know, the majority of people think is not going to be painful, some people will perceive it as painful. And I remember, I just want to very quickly tell you a quick story before we move on, because it all is clear to me now, but it was not when I was, you know, many, many years ago, 20 something years ago. After college, I worked at an abortion clinic in Boston, and I did pre-abortion counseling, education, but then I was also trained as a phlebotomist and a medical assistant. So I would assist the doctor doing the procedure. And I always remember one part of the counseling was to, explain exactly how the procedure goes, what they can expect, what it's going to feel like. And I remember that, no matter what I said, it felt like it did not matter. There were some people that responded in a way that, maybe it seemed like I was pulling teeth out of, with no anesthesia out of their mouth, that amount of pain. And then there were people who were like, oh, I hardly feel that at all. Now, I had no clue then, right, why that might be. And of course, there are many reasons why it might be, but in retrospect, it's very clear, right, that first of all, because of a trauma history or what that procedure means to someone emotionally, they're going to respond differently to what we were really calling discomfort. And that was kind of the main way that we framed the procedure, right? That it shouldn't really be painful. It could be a little bit uncomfortable, but some people acted as if, they were basically jumping off the exam table. And I always was confused about that, but in retrospect, it's very clear. Okay, next slide. Okay, so these are just some examples of incorporating some of these tips that we talked about on the previous slides with using plain language, just so you get a sense of what we mean. So I now need to take your blood for the tests the doctor discussed with you. I will be using a needle to get the blood from your arm. Once I begin, I won't be able to stop. Is it okay to begin? Today, I will be doing a full physical exam. In order to complete it, I will need to examine you in several places using my hands and also my stethoscope. As I go along, I will explain each step before I do it. How does that sound to you? Is it okay to start? Feel free to stop me anytime if you're uncomfortable or have a question. You can also raise your arm if you are uncomfortable, and that will tell me I should stop. Okay, next. Okay, we're gonna move on to what happens during these exams, tests, and procedures. So next slide. Okay, so we've talked about some of these already. Only have the patient take off clothing that's absolutely necessary. Again, everyone feels more vulnerable without clothes on. I think that's probably pretty universal, but for trauma survivors, this may be really amplified. Use a draping paper or gown to cover as much of the body as possible. Consider the temperature of the room and the equipment being used. Try as hard as possible to make the rooms comfortable, in a comfortable temperature for people. Obviously avoid interruptions if possible. Hopefully it will be possible. Explain what's going to happen before. So for example, if you're going to use something that may have a certain scent, be sure to explain, what that is and maybe why that scent may be coming. Use plain language again. I'm going to sound like a broken record, continuing to say that. Asking permission, staying within eyesight if possible, right? So that the patient can always see you, respecting personal space, and using a professional touch, right? So I'd like to listen to your lungs now. I will need to use my stethoscope to touch the middle of your body and parts of your back. Is that okay? Okay, next. So a little more on draping and modesty. Make sure the patient has privacy when undressing. Provide a secure, clean space for the patient to put their personal belongings. Knock before entering the room, and be sure to hear the patient say that it's okay. I love this one. Do not assume that all men are comfortable bearing a full chest, right? Even though we live in a culture and society that says that men should be comfortable with that, they really are not always. Provide tissues as needed or paper towels following any type of examination where like lubrication is used. And the patient should redress privately once the exam is finished, and the provider can come back into the room once they're dressed to discuss results or next steps. Okay, next slide. Okay, so giving clear, specific instructions in plain language. This really speaks to me because I cannot tell you how many times I've been in appointments where they instruct me on how to put the gown on. And I'm not sure if I should leave my bra on or my underwear, or if I'm supposed to have the opening in the front or the back. Now, luckily, I feel confident enough to, again, do the teach back. Wait a minute. Did you say that it's okay to leave my underwear and my bra on and I should have the back, have it be opened in the back? But again, like that, I think is just something that a lot of us think we all kind of know what to do, and that may not be the case. Or we may be uncomfortable with some of those instructions. If possible, the fabric gowns in a variety of sizes are much better. Again, preserves dignity and privacy more than the paper gowns. And if possible, if the patient can move their own gown or their own drape, that's great if they prefer that. Again, that helps you not have to touch them as much. And if they can keep their clothes on and just move some of them around, that's always going to be preferable, okay? So just again, as another example, not that we have to give these to you, but we kind of like to do this. I would like to examine your breasts to make sure there are no lumps that could be a sign of cancer. I will be pressing on them with my fingers and it may feel awkward. Is it okay to move your gown now to begin? Or what questions do you have about this? Okay. Okay, next slide. Okay, this is my favorite part. We're gonna look at some fun pictures. These actually come from the National Council of Behavioral Health. So we did not create them, but we're stealing them as we were allowed to. And we're gonna look at some different pictures and we're gonna decide which one is more trauma informed. I think there was one question I wanna look at. Breast or chest, is there a preferred language for and then transgender community? Yeah, so that's a little bit of a different training. If you are working with a transgender population, then you may not be using breast in the same way, but we could certainly provide some tips or resources on that, although that not even people who really are in that field agree on what the right terms are. I actually used to work at a community health center that had a very big transgender health program. I did not work in it, but the main doctor who worked there always said to me, what I tell them is, I need to take care of the parts that you still have. So whatever those parts are, I'm going to be taking care of them. But there's definitely a lot of resources out there. Yep, always ask the language they prefer. That's fine. Thank you, Sarah Jane, for that one. Okay, next slide. Okay, so you have to do a little bit of work here. 2 pictures. Which one do you think is more trauma informed? You can chat in and just tell us why. So you can chat in the letter and then give us a short explanation. So first we've got B. Okay, anyone else agree or disagree? B is more comforting, okay. Anyone else? The provider can be seen by the patient. Yep. So B it is. B is the more trauma-informed way for a variety of reasons. Yep, the provider can be seen by the patient. That's the first thing. Anything else? Yeah, so in this one, that's really the main thing, is being able to see, right? So not feeling like someone's gonna kind of sneak up behind you, or you're not really sure where that stethoscope is going when you feel it on your back. So B, someone wrote, provider seen by patient, hand on shoulder may or may not be comforting. Yep, that is absolutely true. May or may not be, absolutely. So in that case, they could also ask if it's okay. I'm gonna put my hand on your arm here. Would that be okay with you? Great, These are so fun. Okay. Next one. Next slide. Okay, so A or B here. Which one is more trauma informed? B. Okay. Anyone else? B. Yep. B, you can see the patient can see the provider, right? Looks like she's straining a tiny bit, but for the most part, right, she could still definitely see. Eye contact can be made. Yep. And for someone who doesn't want to make eye contact, right? They'd rather not. This is still okay because it allows them to close their eyes, right? But they're not in that kind of lying down, more vulnerable, position. Anything else about this one? I think this one is really one that lying flat like that and having someone about to do some sort of pelvic exam, which is, looks like what is happening here. This is really as vulnerable as you can get, and this really can trigger, memories of sexual abuse. So having the patient like they are in B is really preferable, much less vulnerable and much less threatening. Great. Okay. I also appreciate how much covering there is. Yes. Thanks. That's perfect. Okay, next one. Okay, so what do you think about this one? And this one's not a comparison, but how do you feel about it? What do you like? What don't you like? Limited exposure of patient. Okay, yep, that's definitely good. Anything that could be better or anything you don't like? The thing I love about these is that they're all very, very subtle. Eye contact. Sorry, so you like the eye contact or you don't like the eye contact? Faces are level. Okay, yep. I do like it. Okay. I would rather a little to the side and can't see the other hand. Yeah. So, I mean, again, yeah, I think everything you're all saying is good. Eye contact depends on the culture of the patient, right? So one thing you'll notice is that the doctor or the provider seems to be pushed up against the patient's knees, so touching. So that's not as trauma informed as it could be. She could step back or step to the side a little bit and not have that contact. And the other thing, while I like the level eye contact, it does seem like she's kind of in the middle of like kind of face to face, and that could seem not controversial. It could seem like she's being confronted, right? Challenged. So that could, she could probably do a little bit better of a job in terms of that. Good. Okay, next slide. Okay, which one's better and why? Again, we're almost done with these. B, okay. Any reasons? B is less inside the personal space. Yep. Smile. Yeah. In healthcare, we're never good at like making videos or taking pictures to explain how we, for examples, we need more Hollywood help for things. Yeah, so, sorry, no stethoscope, limited medical gear. Yep, that's good. B, minimal physical contact. So in A, I'll draw your attention to the fact that the provider's hand is a little bit close to the pelvic area. even though it's on the wrist. So again, that could be something that that person wants to think about. And it's super subtle and you can barely see it. But in A, she's a little bit, the provider's a little bit closer than in B. In B, she's a little like step back and her wrist, only her fingers are touching the wrist of the patient, as opposed to in A, where her whole hand is resting on the patient's thigh or upper thigh. But as you can see, it's really, really subtle. But these little subtle things can make a difference. Okay, next slide. And Andrew just chatted in, the patient is sticking her arm out. She's having the opportunity to offer her hand versus the provider intruding on her personal space. Yeah, that's great. What about this one? This is the last one. B, because there's less physical contact. Yeah. B, she's outside the patient. Yep. Yeah, so you'll see there's kind of the same themes, right? Minimizing touching, that's not necessary, right? The field of vision and, you know, where someone stands and the placement of, you know, instruments and hands. So again, these are all really subtle, but it's amazing that they can really make a big difference. B, the patient looks uncomfortable with how she's holding her arm out, shoulder. Yep, could be, although that might be more comfortable than the provider standing right up against her knees. I like to go to when I go to the doctor, I barely can spend any time on my own personal stuff because I'm always thinking about all this stuff and critiquing them on how they're doing. And I forget about my own reason why I'm there. Okay, next slide. Me too. Thanks, Virginia. It's a curse. Okay, so very quickly, if the patient, you know, seems uncomfortable, these could be really self-explanatory. Pause the exam, step away from the patient, avoid sudden movements, ask the patient how they're feeling and what you can do to make them more comfortable, reassure the patient that they're safe and remind them where they are, consider changing environment, again, if it's possible, moving to a different room. So, right, here's another example. I'm noticing that you're tensing up when I touch your back. Is there something I can do to make this more comfortable? Is there something you want me to know about being touched there? Okay, great. Next slide. Okay, now we're going to just talk quickly about after what happens. So next slide.
That's me.
Yep.
Thank you so much, Yael. That's so helpful. And those pictures are, I mean, I know when we were first looking at them, I had to look at it like 5 times,
Yeah.
So subtle and make so much of a difference though in thinking about trauma. So, you know, we get through the exam and what happens next? It's really important that we thank the patient for collaborating with us, right? So it was something that was done together, again, rather than something that was done to the patient. We want to discuss the results and next steps using plain language, using the teach back method, and using open-ended questions like, what questions do you have versus do you have questions? And I know that this is very particular depending on the practice and provider, but even in thinking about teach back method, is there a way to incorporate technology? For example, if you know, is it okay if you are showing a person how to wrap their arm that they can videotape the actual wrapping of their arm without a person, you know, without showing faces, but things like that, because I know I've recently experienced this myself. Went to a physical therapist, they showed me how to wrap my ankle. I was like, I'm good to go. Went home, could not remember for the life of me which direction and what to do. And so, you know, just trying to be creative about what that might mean. So again, here's an example of what we might say at the end of the encounter. I want to be sure I did a good job explaining the new medication you'll be taking because I know it can be confusing. And sometimes I don't explain it well. So can you tell me exactly how and when you will take it? And Yael did such a beautiful job of going through this earlier. So next slide, please. So what does all of this mean now in the new normal? And I don't know how long we'll be saying new normal. There's nothing normal about this, right? So, just a reiteration of things that we've covered before, but, and that have been, we've been doing this, you all have been doing this, but it means something different now, right? So keeping spaces clean and organized, and even sharing with patients how you're doing that, right? There is a sense of safety if you're letting people know this, these chairs were just sanitized for you, or there's a sign that says that, right? Provide hand sanitizer in multiple places. We want to post clear signs about mask requirements and provide masks as needed and if needed. Definitely using images in addition to written signage. I think that, signs and faces, especially for mask wearing, has been really, really effective. If this is possible within your practice, providing and expanding on options for telehealth visits can go a long way. And I think that, we're moving more and more toward this as something that will probably remain, even if and when we ever do go back to the old normal. And then thinking about, offering more flexibility about cancellations or last minute changes to scheduled appointments. So rather than, those policies that we have in place for good reason, trauma informed would be taking into consideration what the pandemic means, especially on our patient populations. And more than ever, it's important to explain things now. And having to explain sometimes more than once, and being open for questions, I think means more than ever now. Next slide, please. So what does this mean if you are seeing patients that are young, adolescents and children? So we're going to go through a few additional tips, right? Everything that we've spoken about really do apply here, but there may be additional considerations or slightly different ways that we would do this. Next slide, please. So thinking about children, so we're thinking when I use the word child, I'm thinking about preteen up through age 12. Children's reactions during routine checkups obviously can vary greatly on age and temperament. And to any of you who are parents, I'm sure you're like, yeah, duh. And so again, really having to take into consideration each patient on an individual level is so important. Fear of the doctor is an issue that resonates with many families. I don't know about you, but definitely growing up when I was a child, to hear that I had to go to the doctor for anything was terrifying. And I have positive experience, memories of who those doctors were, but just the anxiety and anticipation of what we were going for. And that usually as a child, it usually does involve needles. And I do know that that was a terrifying word. Half of parents of toddlers and preschoolers say that their child is afraid of going to the doctor. And again, mostly because of shots. So based on one national poll, 1 in 25 parents had even postponed a vaccine due to their child's anxiety. And that a nationally representative survey found that 1 in 5 parents struggled to concentrate on what the doctor or nurse was saying because their young child was so upset during the appointment. So, this is so important because the parent needs to be able to focus, right? So if we're putting all of that responsibility on that parent or caregiver of your child patient, what is their capacity to be able to remember, understand, to apply to the child later? Next slide, please. So some tips, and again, always open to hearing other people's suggestions or experiences that you've had if you do work with a lot of children. Um, preparing the child ahead of time for the visit again, and that would be extended to also preparing whoever is bringing that child in for the visit, right? Um, we obviously don't have control over parent communication with children, but we certainly can arm the parents with suggestions and more information so that they can apply it to their child, whom they probably know better than most people. We want to engage in conversation about non-medical topics first with children. I think this is great for all patients, to be honest, but that's a luxury of time that most providers don't have. But certainly with children, it's necessary. You want to ease anxiety. You want to signal that this is a safe space. You don't want to blindside a child in any way before performing any sort of exam or procedure. This also can help put the adult or caregiver at ease as well. We want to be mindful about making children feel comfortable without making jokes about procedures, right? This is kind of tough because I know, like there is a fine line here, but we still want to treat that patient, even if it's a child, with dignity, with respect. We want to be as honest that is age appropriate. And we also don't want to minimize or dismiss what that experience is going to be for that individual child. Children might have different ways of expressing how they're feeling, but they feel, none the same. So want to be careful about making empty promises. So telling a child, this won't hurt at all, this is no big deal, is going to set that child up for a lot of distrust later. And I think that, this goes back to what Yael was saying as well. For any person, including children, it's hard to tell another person how something is going to feel. Offering distractions, right? So this is tough during COVID time for in-person visits, but certainly you can have things that are individually wrapped, or even suggesting to bring something in. But having toys or other objects that a child can hold, play with, look at, listen to during the exam can be really helpful. Again, paying attention to nonverbal cues is going to be really important, especially for children. And we want to speak directly to the child during the visit rather than just addressing the adult parent or caregiver. Obviously, what you'll be saying to one is maybe different to the other, but we want to make sure that it's clear that we see that child and that they are the primary patient in this particular experience. Ask for permission to touch. Again, most children are going to defer oftentimes to their adult parent or caregiver, but it's really important to respect that and also to model what kind of healthy boundaries and healthy touch mean for a child. And I think it's so important because children are learning very different messages around kind of bodily autonomy. So we're telling children to be safe and no one should touch them, good touch, bad touch, but then we're not applying that necessarily when it comes to roles of where people are, in positions of power like medical doctors, and that can be very mixed messages. So we highlighted this because this has been written in some medical digests and hearing from professionals that consider giving children a small gift afterward, or a reward for this is helpful. Some of my best memories as a child was, the doctors when you're leaving and you got to pick out like a toy from their treasure chest. This could also mean some parents also sometimes need other ways of, getting some cooperation from children. Yes, someone's listening here. I would make sure to give the gift in the presence of a parent guardian. Absolutely. So something though that is affirming, right? This child did a great job for coming. And I think, ways in which we can do that can be creative, and you probably know what your patient population would respond to best. Next slide, please. So teens are going to be different, right? Again, some of these same principles apply, always preparing a patient ahead of time. With adolescent patients, having some time alone with the patient is is important and should be part of, standard care. Um, Although minors can't necessarily consent to certain medical procedures on their own, you can certainly have alone time with them, and there is a certain level of confidentiality that providers can have with their adolescent patients, right? So, part of this is really knowing what that means depending on the state in which where you are right now. But it's really it's a good practice to have that time alone. Many parents expect that this is part of the course, and so for parents to be asked to step outside, or it's not mandatory that they come into the exam room, or it should be up to the patient. These things should become part of just the general practice. And certainly do not put the teen on the spot to ask if they want their parent to leave the room when they're in the room together, right? We don't want to set up some really, challenging outcomes after they leave the appointment, but it really should be, again, one of those standards of care. I always like to have a few minutes alone with all of my patients, and to have that time. Again, the body language, nonverbal cues are so important. Put this in here around believing your patients, specifically teens. Again, this idea that younger people don't know themselves or their bodies in the same way that adults is something that we really have to let go of. Teens need to be treated in an age-appropriate manner. So we don't want to talk to teen patients the way you would with a child, right? And again, speaking directly to that person and always asking for permission to touch. Next slide, please. So some small practice considerations, involving patients in treatment plans, again, is best practice across the board. Small practices can allow this to happen a little bit easier, to have a more closer one-on-one trusting relationship where you have the opportunity to maybe get to know your patients a little bit better than a larger practice or a larger, system. Staff may play multiple roles, where, an MA may be at the front desk and doing triage. So again, really clearly stating individual roles and responsibilities would be essential in these situations. Creating a safe environment and considering all aspects of the physical space and its relationship to sensory stimuli. We did a webinar on this. So if you haven't seen it yet, it could be really helpful, specifically around small practice considerations and things that are, within the realm of reason, adjustments that can be made in this particular area. And then considering offering flexible schedules to those patients who are apprehensive or have exhibited signs of trauma or have disclosed, right? So things, maybe you can assign those patients to later appointments where you might not have patients after that or the last appointment, knowing that you may need some additional time, or that the patient may need additional time. Next slide, please. And so we are at the end of it. This is the opportunity for people, we'd love to hear the questions that you have or thoughts around what we just covered.
If you do have to head out, we totally get it. If you can do the evaluation, that really helps us. We would really appreciate that. You'll be directed to it when you leave. Thank you.
Thank you for coming, Deborah. Yes, thank you. Sunday sent in I always get the consent of a teenager, especially girls, if it's okay for a one-on-one exam, or if a chaperone is needed. Absolutely. Thanks so much. And Kimmy has posted the survey if you have a few minutes to fill that out. Thank you, Virginia. Yeah, we're so excited if you want to share this with other colleagues and other providers. That's amazing. The more we can have these discussions, the better it is for all of our patients.
I have a funny anecdote. I think I shared this with Angela while we were preparing the training, but I have a mom friend who has a 12-year-old daughter who is terrified of going to the doctor, like terrified of vaccines, getting blood, anything. She actually has some sensory issues, so it makes sense. But my friend's solution to this is she doesn't tell her when they're going. They get in the car and she doesn't know where she's going until they get there. And I have a lot of good laughs about it when I'm with her and we're just like having a drink, but I've always, it's hard to know, right? Because my
Right.
friend's like, if I tell her, I'm literally not getting her in the car. So, but I'm like, well, that's not very trauma informed. She has to tell her, you should tell her what to expect. And my friend's like, no, if I do, we're never getting there. And then she's never going to get any of those things she needs. So also like
it's all
flexibility.
It's all about weighing.
Yeah.
Yep.
Like we have to be
weighing
person
those pros
centered.
and cons.
Yeah.
Exactly. I always think too, like it's so much easier to apply all of this to situations that are not your own personal life, right? Much easier for me to be trauma informed when I'm not dealing with a close family member. Then it's really hard to apply some of these same things.
Exactly.
And I'm like, here, how much will it take? I will bribe you. Just do what I'm asking you. There's no discussion here, no question.
Any more questions or comments?
One thing I did want to bring up too that I forgot to mention earlier in the pre-visit and triage, that it can be helpful to let patients know that, if they have multiple things that they want to discuss or they're coming with, come in, bring a list, bring your notes. And as providers, sometimes that makes life even easier. If a patient comes in and here's what they want to address or here what their concerns are, you know where to start with your patient.
Yeah. And I always said that we really, along with like a lot of places now do the text messaging, or the email confirmations, I'm really an advocate for putting something in that about what you just said. Like, please confirm your appointment. And here are, what are the 3 top things that you want to discuss, with your doctor. I mean, you could either say, write it down and bring it, or it would be amazing if you could write it and it got back to practice.
That would be incredible.
I can't imagine that technology is very challenging at this point. We could do that.
I know I definitely walk around with lists now, just to stay focused, because I know, my provider doesn't have a lot of time. And so this helps me, because honestly, sometimes I get nervous just being in that room. All of a sudden I'm like, so it helps me to stay focused and not leave and then go, God, I wanted to ask about this and now I forgot.
Okay, well, I guess if no one has anything else, we'll let everyone get on with their day. Thank you all so much for joining.
Yeah.
Always, this has been recorded and it will be available on our website. I had sent out the link earlier, but you'll also, I believe you'll get it as well as an email. So thank you so much. And we will hopefully see everybody next month and have a great, as well, have as good a Christmas and New Year's holiday season as you can. I don't know about any of you, but I'm very, very ready to see 2020 come to a close. And hopefully
I actually accidentally wrote 2021 on a page where I was putting a date. I'm already gone. I've already left 2020.
Yeah,
Started putting 21 already.
I'm ready for 2021. Good things are going to hopefully be happening in 2021. So thank you all and take care.
Thank you.